All right, so good morning. We're going to get started, and everybody hope maybe get a few extra minutes at lunchtime. So welcome to Workshop 8, Best Practices and Approach to Clinical Research, including Community Engagement. I am Katie Posch, and this is my co-chair, Julia Giancola. Here is the session disclaimer, and we have nothing to disclose. This session is going to explore innovative approaches to clinical research, focusing on strategies to improve efficiency and engagement that prioritize both scientific integrity and patient-centered care. If you have questions, there will be time after each presentation, so you can either use the app or the microphone that's in the middle, but they have asked to let you know, please do not move the microphone, just keep it right there. Our speakers are going to talk about decreasing data entry time through workflow optimization, effective strategies to support remote studies, and building strong partnerships with clinical teams and community members. Our first speaker is Felicia Reed. She is currently the Senior Research Program Specialist on the Partnerships for Sustaining Daily Care team at the CF Foundation. Felicia supports the management of the Success with Therapies Research Consortium, Partnership Enhancement Program, and the Mary Contos Care Champion Award. She's passionate about community empowerment, advocacy, and partnering with people with CF and their families within the community. In her free time, she has recently taken up golf, so any tips she would appreciate, and I will let her introduce her presentation to you all. And so then it's just arrows on the mic.
All right, good morning. Thank you for that introduction, Katie. My name is Felicia Reed, and this morning I'll be presenting Empowering Voices, the Personal Impact and Value of Community Participation in CF Research. And the only disclosure I have is that I'm an employee at the Cystic Fibrosis Foundation, and I have no other disclosures related to this presentation. Okay. Created in 2014, the Success with Therapies Research Consortium, or STRC, partners with people with CF and families to facilitate clinical interventions that support a holistic approach to self-management. And I won't take too much time reading the full mission statement, but I would like to note and highlight a few key words in the mission. And that is, all interventions are created, implemented, and distributed in collaboration with individuals with CF, their families, and care teams to ensure that the interventions are people-centered and empower people with CF, consider everyone's different life experiences, backgrounds, and cultures, be adapted to people's strengths and needs, flexible and feasible, and of course include validated measures of adherence and self-management in CF. And this truly speaks to the essence of the STRC, that it was built for and with the community and is apparent in the consortium's mission statement. And that's the key distinction for the STRC, the value that is placed on community stakeholder involvement. And this slide shows the consortium's infrastructure. So the STRC is composed of 3 cores: the Study Management, Data Management, and Operations Core, as well as the Steering Committee, which is its governing body. And each aspect of the infrastructure of the consortium places an emphasis on supporting community input at each point. And the voices of the people with CF and their families are included in every aspect. And for today's presentation, I will be focusing mainly on the Steering Committee. Okay, some responsibilities and what our committee members do. So this slide just provides a high-level overview of the responsibilities for our members. And at each checkpoint, the steering committee ensures the alignment with the CFF's mission as well as the STRC's mission that I shared earlier. At each checkpoint, the steering committee ensures alignment as well as speaks to the intent of the mission to ensure all aspects of our community are part of governance and research processes. And this is a very active role. Our community members are involved in high and key decision-making processes. And some of the decision-making that they're involved in includes study ideas, research proposals and designs, study protocols, sanctioning of research studies. And we currently have 5 community members that include adults with CF, parents of children with CF, parents and a parent of an adult with CF, as well as 3 academic members and our co-chairs. And the onboarding process. Okay. So for our onboarding of community members, we start off with a call of applications through Community Voice. And once responses are received, we do a review and select our top 5 candidates that are invited for interviews. And then at the interview process, we let our community members on the steering committee lead the interview process. They give us their final thoughts and recommendations before we select and onboard our new community members. And I will note this is a 3-year term, so it's a very big commitment that we're asking our community to take part of the steering committee. And on average, we have there's a 3-year term, and they are primarily on the steering committee. So what is the point? I shared a lot of background on the consortium's infrastructure, shared some mission statement and high-level overview of our consortium. And the point of this presentation today is to really look at the value and the impact that our community members have on the SDRC. We recently had our 10-year anniversary last year, and it served as a point of reflection on, are we meeting our goals? Do we really have a bi-directional relationship with our community members where they feel they are receiving value from the research we are putting out, and vice versa, we're including their personal experiences in our research design? So we sent out a survey. We surveyed 12 current and former community members through a survey that was conducted for 3 weeks. And the survey questions included the duration of engagement, collaboration on other CFF initiatives, perspectives on their experience with the STRC, and how the experience impacted their outlook on CF research as a whole. And for the results, we received 8 responses. And on average, our community members were engaged with the STRC for 3 years, but that was not just stagnant. They were a part of advisory groups, ad hoc protocol reviews, and a few were invited to be study PIs. And for half of the community members that joined and took the survey, this was their first time in engaging in any type of CFF initiative. So it was their first time reviewing protocols, sanctioning, being a part of any type of CFF research. Okay, and this pie chart shows just a reflection of how participation was spread across the SDRC, with the majority sitting on the steering committee, but a few also being a part of advisory boards, working groups, invitations to be study investigators, and other roles throughout the consortium. Okay, and when asked about their feelings of inclusion in the SDRC, majority felt very included in our initiatives, studies, working groups, and decision-making, with roughly 12% feeling included and roughly 12% feeling neutral, neither included or excluded. When asked in agreement with this statement, the STRC's research has value to the greater CF community because of its real-world approach. A majority felt strongly about this in agreement, and with 25% feeling that they agreed. When asked if the STRC has fully integrated the community perspective in their research designs, majority also felt, roughly 87% felt they strongly agreed with this statement, with about 12% feeling neither they agreed nor disagreed. And results continued. Okay. And for the folks that had never participated in any type of CFF research, a majority of them did go on to work on other CFF initiatives as well. And I listed a few, but I couldn't include all, but from the list, you can see that they become highly involved, and the SDRC did serve as a springboard for other engagement in CFF-led initiatives. So I've listed the Adult Advisory Council, Genetic Therapies Working Group, SUN-CF, and Envision, just to name a few. And the impact of participating in the STRC. So the community members were also asked open-ended questions, and they provided their thoughts on the experience with the STRC, as well as their own personal journey being involved in CF research. And those were categorized into 4 thematic themes. And they were personal and intellectual growth, appreciation for research, engagement outside of the steering committee, and inclusiveness of community members at crucial decision points. So the next few slides will be quotations. So for personal intellectual growth, this quote highlights this. This community member wrote, "I worked on the steering committee for a couple of years in the mid-2010s. I found the experience to be empowering, as I felt I had a chance to give patients a voice as to how complex our treatment regimen can be and help researchers find ways to address that burden. As this was my first involvement with CFF, it ended up creating relationships and open doors to help with more initiatives, which I have continued to do. Before that, I had helped at the local level, but this was my first experience working with the foundation on a national level, and it was very fulfilling." The next quote provides insights into the appreciation of research and personal impact. "I am honored to be included in this work. It has given me deeper insight into the important research the CF Foundation is doing, and I'm grateful to be involved in shaping research that directly impacts my life, my sister's life, and the lives of the CF community. I have provided input on research protocols, research survey questions, and reviewed study site applications. I am glad that other community members are also providing feedback alongside me, and so that the community is represented by more than one perspective." The next quote speaks to the appreciation of research as well. "Engaging with this STRC has taught me more about research methodologies and processes. I have learned about research design, questionnaires, recruitment, and decision-making. I have seen the commitment of CF researchers to improving the health and well-being of the CF community. I have also learned more about CF care options and practices that I did not know about previously." Okay, and this quote speaks to engagement outside of the steering committee. "I was part of the STRC steering committee for a term. I learned about the different STRC initiatives and was able to give input that was heard and taken into consideration. Some of the projects I participated in were the mHealth workshop, the daily care check-in, and the competitive renewal review for participating centers. I then continued the adult nutrition working group, and I became one of 3 Eaton study PIs. It has been a great experience, giving me the opportunity of learning a lot about qualitative studies, and I've been able to represent the CF community through my personal experience as well as others." One more quote for engagement outside of the steering committee. "Palliative care guidelines, pain management guidelines, Research Con Food Insecurity Committee, TDN reviewer for proposed studies, as well as part of the NACFC session in the fall. But my key message is that CFF integrating the patient voice into research has been empowering to patients, but I think also brings insights to the process that may not occur to those not living with the disease. For me, STRC was the start of working with the CFF at the national level, and I will be forever grateful for the opportunity." And this last quote speaks to the support of inclusivity of community members at crucial decision points. "On the Yeti study, I helped to pilot test survey questions with both my children. We had developed these questions as a study team and in meetings. They seemed absolutely perfect and clear. When piloting them with kids, I could see how differently a child or teen might answer or understand them. It was very rewarding when the study team valued our family's feedback on question wording and structure." So what have we learned from this? There is still room for improvement, but we can see that from the survey questions and the thematic quotes from our community members that there is value in the participation and impact of what we do. But the intent of the consortium, what we set out 10 years ago, to ensure that the aspect of community members being a part of our governance and research processes, still there, it's still valued, and it's truly integrated. And from this survey, we learned that our community members go on to do different things after working with the STRC. And that involvement in the STRC served as a springboard to engage it further at the foundation. And to continue that, the bidirectional relationship that we set out all those years ago between researchers and the community, it's there, it's active, it's alive. How much time do I have? Okay. And with keeping with that spirit, there's always room for improvement, but our community perspective and research ensures that interventions address the interests and concerns of people with CF, their families, while supporting CF self-management. And if you are interested in learning more about the STRC, I will be presenting this abstract on Friday for poster 388. And I've also included a citation for our publication on the STRC, which speaks in depth to our structure, our committees, as well as how we function as a consortium. And last but not least, a special thank you to our community members, past, present, and future, the Partnerships for Sustaining Daily Care, also my co-authors for this talk, our STRC leadership, and of course, our consortium that includes our investigators, research coordinators, data management, and study management core. And of course, you, the audience, thank you so much for listening, and I will take any questions at this point. Do you want to use this?
Okay. All right, thank you so much, Felicia. That was great. I do have a first question here. What are some of the challenges that you've experienced recruiting community members?
Thank you, Julia. I'd say the hardest or the biggest challenge we've experienced is in the recent years, because we've expanded to include more community members to make up half of the steering committee, it's been hard when we do our call for applications receiving an overwhelming response from community members that want to join. This year, we also completed a call for applications and received roughly 24 applications for a position we were only taking 2 spots. So I think the biggest thing is we want more voices. We love to hear everyone's personal and lived experience to add to the richness of our research, but we have limited spots. We only have 2. This upcoming call for applications next year, we'll have 3 open slots. So I'm hoping we'll be able to take on more folks. I say that would be the biggest challenge.
All right. Thank you so much.
Okay.
All right, I'd like to invite our next speaker up. It's going to be Vanessa Mauricio, and she will be speaking on paving the way, integrating research education into clinic to forge new partnerships. And Vanessa is a CF research coordinator from UVM Health. She's been a CF coordinator for about 3 years, working on both observational and interventional trials. She did both her undergraduate and graduate programs at UVM and holds degrees in microbiology, public health, and medical science. In her free time, she enjoys rock climbing and hiking. So come on up.
Hi, everyone. I am super happy to be here. I'm Vanessa, and I'm going to talk a little bit about our QI project that we did at UVM Medical Center entitled Paving the Way, Integrating Research Education into Clinical Visits to Form New Partnerships. And I do want to give a shout out to everybody you see listed on the slide. Our work would not have been possible without them and our clinical team, and of course, our wonderful patients. The only disclosure I have for this is the work was completed as part of the EQIP-CR program funded by the Cystic Fibrosis Foundation. So I thought it would be pretty important to talk a little bit about our center background. Our center population has roughly 104 adult patients and 68 pediatric patients. We have all clinical CF subspecialties, pharmacy, nutrition, social work, respiratory, we include research in this too, and nursing. Our center is very involved in clinical trials. We have over 25% of our center population enrolled in TDN sanctioned trials, and 15% of our center population is enrolled in observational trials as well. If you take a look to the graph on the right side, I included some of our center metrics. So when we weight the number of subjects enrolled into TDN studies as a percentage of our center population, we actually emerge roughly between the 1 and 3rd spot in the past couple years. So that's pretty exciting, and I think it's a true testament to how committed our patients are to participating in the science. Instead of the problem, I'll say the onus for our quality improvement project is there are lots of CF subspecialties for patients to see on any given clinical visit, which is a common sentiment among most centers. And as a result, sometimes research visits would get dropped and missed when clinic was busy. And what happens then is it hurts study recruitment and has the potential to interfere with research data and sample collection as well. So we needed a way for research staff to connect with our patients ahead of recruitment, and we also wanted to improve patient education on research and keep patients engaged and excited about the different advancements in CF care. So our idea. We wanted to create research visits for everyone, regardless of study participation, prior or current. So what would happen is once a year at a clinical visit, we would do a research education on a specific topic. And we tried to do a new topic every year. In 2023, we did genetic therapy. And in 2024, we did bacteriophage therapy. So all of the data that you see from this presentation is actually on the bacteriophage therapy questionnaire. So what we did was we created a questionnaire. It was administered before and after education, and it was aimed at measuring understanding as well as opinion of our patients on participating in trials, both phage and in general. We had a few key goals here. We wanted to improve knowledge and understanding of our research topics and our patient population. We also wanted to gather data on patient opinion of research, hopefully improving their opinions on participating in future trials. And we also wanted to foster connections with all of our CF patients that don't normally get seen by research personnel. So this is just a questionnaire that we developed. We have various different questions. Some are aimed at gauging understanding of the education topic. So I think about questions like 1 through 3 for that. And then we have a few questions that are more clinical in nature. So statements like, I have a good understanding of antibiotic resistance. I have a good understanding of my own infection status. And then question number 7, I would be interested in participating in a clinical trial if I became eligible, was a very important question for us research personnel. And just some more about our methods. So our survey was administered before education and after education in about 61 of our adult patients and 34 of our pediatric patients and their families. In the pediatric population, we kind of gauged who would fill out the survey based on, child age and aptitude for understanding questionnaires. A lot of times the parents would also be involved in filling out the questionnaires, so it was very collaborative and fun to talk to everyone. We gave patient education handouts, so we developed that handout over onto the right. And for our education, we basically just went through the handout, administered the post-survey, and then for the project, our survey results were analyzed. So in the next series of slides here, you'll see all sorts of histograms highlighting, I picked the most striking ones for this presentation, the pre and post data in both the adult and pediatric populations. So this first question, I know what a bacteriophage therapy is. As you can see in both the adult and pediatric populations, the strongly disagree category is denoted as number 1, totally shrunk in the post-survey. So the dark blue, everything also on the histograms that's darker in color, you can see the movement of patients in the different subcategories. So we're really looking for movement from the bottom half of the graph to the top half of the graph. And we saw just marked reduction in both populations for this, with growth in the agree and strongly agree categories immediately following education. The next question, I have a good understanding of phage therapies and how they are used in CF care. Similar trends for this one. We saw very strong reduction in the strongly disagree category, so that's good. Most people developed increased understanding of phage therapy and understood how they might be used in cystic fibrosis care. That happened in both the adult and pediatric populations. I understand how phage therapy could potentially impact me in the future. This one I thought was pretty cool because in the adult population, we saw a complete elimination of the strongly disagree and disagree categories following education. So people were either neutral on the topic, agreed, or strongly agreed that they understood how phage therapy could potentially impact them. Similar trends happened in the pediatric population with a complete elimination of the strongly disagree category, and most people following in the agree and strongly agree categories following education. I have a good understanding of antibiotic resistance. I thought that this was an interesting one because it's more of a clinical question, right? A clinical topic being taught by research personnel. Or reinforced by research personnel, I should say. So in both the adult and pediatric centers, we see reduction with complete elimination of the strongly disagree and disagree categories in the pre-survey, with most people falling in the neutral, agree, and strongly agree categories. In the pediatric population, the strongly disagree category was eliminated completely, and most people end up falling in our agree and strongly agree categories following education. And this is another sort of clinically driven question. I have a good understanding of my own infection status. For some of our patients, we introduced their own, infection status and just kind of like reminded them what they were culturing, if they cultured anything historically. And we also saw a reduction in the disagree categories and the strongly disagree categories, with the complete elimination of the strongly disagree category in the pediatric population. So following education, most people were either neutral, agreed, or strongly agreed that they understood their own infection status. And this was my most favorite one. The positive perceptions of research in both populations following education were shown to change in an increased and positive way. So this was question number 7. If you'll remember, it was, I would be interested in participating in a clinical trial if I became eligible for one. So I highlighted here the neutral category, which falls under numeric value 3. And we saw movement from a neutral category to agreeing. And same thing with the pediatric side. They agreed following education that they would like to maybe participate in clinical trial. So if you take a look cumulatively, we see about 12% increase in positive patient perception of research following education by research personnel. So we had a few key takeaways. Research education, improved understanding, and the perception of research. Research staff could maybe be utilized to do other types of education, just not only focusing on the research, but maybe some of those harder scientific clinical questions as well when appropriate. And the results of this might be used to inform clinical flow decisions, so making sure our research personnel and our research coordinators get in to seeing our patients and forming those really strong connections. I do want to point out some limitations to the data and our methods here. So our longitudinal knowledge retention wasn't assessed. We gave the surveys immediately in clinic, prior to and immediately following education. And as a result, I try to think about demand characteristics when we're thinking of these things. So observer bias could be a potential influence on the survey results. And because the research personnel were in the room with the patient as they were doing the survey. And our results were totally anonymous, so we can't track future research participation of those patients that moved from the neutral to agree categories. So that's just some limitation, but hopefully we can continue to work on this in the future. And for our future directions, we are going to be continuing research education with our patients. Our 2025 topic was mental health and CF, and we are going to try to workshop another topic for 2026. So if anyone has ideas, just let me know. And any questions? Thanks so much for listening. Do you want to come over here? Yeah.
Right, we do have a question here. It says, is the bacteriophage educational flyer handout that you created, is that something that's available on the CFF website?
That's a great question. Thanks for asking. It's not currently available, but I'm sure we can connect with some folks and make it available to you. And you can also come up to me. We're actually at poster 771 tomorrow, which is an odd poster, so it's at the odd poster time. Feel free to come over, and I'm happy to share that with you electronically.
One up there.
Yes, we'll go up there.
Go for it.
Will you repeat that question back so everyone can hear it?
Yeah, definitely. So the question was what we did to prepare our RCs for these very scientifically driven topics. And at UVM Med, we actually have a pretty unique setup. We've got a small coordinator team, myself and Julie Sleet, that's over in the audience. Hi, Julie. And we really worked on developing these things together. So we did the handouts all together. We went through the resources, and we did all of our research together. On larger coordinator teams, I would maybe recommend having a meeting and having those continuing conversations as the science develops too. I'm so glad you asked that. Thank you. So the question was how long these education sessions would last, and totally understandable because there's a lot of different competing clinical priorities too while we're having these conversations. We approximated about 7 minutes, more or less. Sometimes folks had lots and lots of questions. Sometimes people just didn't really talk and they listened, and that's fine too. So definitely something to workshop. Thank you.
One more. You alluded to it a little bit, but exactly how do you determine the topic for the following year?
That's a great question. Thanks to the person that asked that for us. When we're picking topics, we derive a lot of our inspiration from NACFC. So hopefully we'll take a lot of good ideas back to the drawing board with us following the conference. I also think that we try to pick topics that are pretty generalizable to our patient population and have the potential to, well, they might not impact the patient at the current moment, they might impact them in the future. So that's kind of where the phage therapy came from. And then the genetic therapies, everybody is just very interested and has lots of questions, and it certainly has implications for all of our patients in future years too. So the generalizability, and then also just things that are very exciting to us. Great. Thanks, everyone.
That's Sarah. Great. All right. Our next speaker is going to be Sarah Schwartz. She will be talking about decreasing the CF Foundation patient registry encounter data entry time. And Sarah Schwartz graduated from the University of Texas at Austin with a Bachelor of Liberal Arts degree focusing on classical archaeology and ancient Greek. She has worked in the research department as CF patient registry coordinator for the pediatric and adult CF centers in Austin, Texas since 2016. In her spare time, Sarah enjoys creek walking, arts and crafts, baby animals, and playing the piano. Come on up.
Thanks. Oh, boy. Okay. Oh, well, hi, y'all.
My name is Sarah Schwartz, and I'm a research coordinator at the CF Centers in Austin, Texas. Today, I'm presenting my abstract on decreasing registry encounter data entry time. I'd like to go ahead and thank my coworkers who are part of this project with me. And please stop by to see my poster 770 at the exhibit hall. Here are my disclosures. I have no relationship to disclose. All right, let's start from the beginning. What was the problem? Well, the problem was that in 2023, it was taking too long when entering our encounters into the registry. From 2016 to 2023, we had only one research coordinator doing data entry for both peds and adult, and that was me. After 2016, and as years went on, I became more familiar with all the aspects of the registry and also got more granular with data entry and data capture. In addition, I would receive requests for trends in our population that would lead to complex, time-consuming queries. So I began tracking more and more data points year after year on a separate spreadsheet, which provided some data that the team needed in real time, but also slowed us down. Our patient population has been growing year after year, so that means more data. Our combined peds and adult consented registry participants went from 282 in 2017 up to 323 in 2023 when we started this project. Also, every year, the Cystic Fibrosis Foundation releases more data points to collect. And we also grew our pulmonology research team by adding a new coordinator that needed cross-training. So data log time in February every year was really stressful, and I planned my vacation in March for a reason. I'm sure some of y'all registry folks can relate. Why was this a problem? Our team performed well on quality scores in the annual program-specific report, and externally, the process looked great, but internally, we were scrambling to make it work. The problem we needed to solve was how to speed up the time it takes to enter and complete encounters without sacrificing quality. We needed to be fast and accurate. Why does this matter? By finishing encounters faster, we have more time to work on quality improvement initiatives, consenting patients, and arranging study referrals. So I would start an encounter in the registry within 30 days of the date of service happening as per the CFF data entry guidelines. And this is a very firm deadline. And I had this part of the process down pat. So yay for timely data entry. And timely data entry is crucial for pulling data from the registry for quality improvement projects, supporting TDN studies, and ensuring current and accurate data. But what I did not have was a deadline to complete chart abstraction and data entry for these encounters. So I would be weeks to months behind on completing encounters, which created a backlog of unfinished encounters and hampered our ability to do QI in a timely fashion. Like any good QI, we had to have an aim statement. Here is ours. The research coordinators aimed to decrease the amount of time for data entry from an average of 30 minutes down to under 20 minutes for pediatric encounters by December 31st, 2024. Now let's go down this rabbit hole together. All right, where to begin? Well, our team had to review our baseline and had to brainstorm to get our data entry time lower. Of course, when you have multiple chefs in the kitchen brainstorming, there are a lot of differing opinions going around. It took weekly huddles over a period of multiple months to sort things out, not to mention poring over hundreds of spreadsheets in rows. No joke. How did we do all that? Since the pandemic, I have been partnering with the clinics to track our patient encounters for each appointment day in a spreadsheet tool called the Clinic Flow Board, or CFB. Starting in early 2023, I began notating my start and end data entry times for each encounter onto the clinic flow board spreadsheet. That is to say, how many minutes it took to start an encounter in the registry, and then how long it took to extract the data from the chart, finalizing it, and submit the encounter, effectively ending it. So it's basically been an ongoing time study, and in the beginning of 2025, we finally began to analyze the pediatric time totals. Also, in mid-2024, we met with our leadership to troubleshoot and modify our process together. If you would like to learn more about that clinic flow board, you can find our center's published abstract from October 2020 here and on the reference slide at the end. Okay, back to methods. To break down these steps a little more, we implemented 3 Plan, Do, Study, Act PDSA cycles. 1, training a new research coordinator on data entry. 2, training an existing research coordinator to assist with data entry. And 3, examination and modification of workflows. In April 2023, the department hired a new pulmonology nurse research coordinator with the intention that part of their scope would be to assist with registry data entry. In 2023, I trained them on how to create registry encounters, enter PFTs, and finalize respiratory culture results. In 2024, they started ending encounters as well as starting them, all while notating their start and end data entry times on the CFB. While they were doing that, I was able to target ending encounters. We divided the work and were able to focus on our portions like an assembly line. The assembly line was our first intervention intended to increase speed while maintaining quality. We saw improvement, but still had a backlog of encounters to finish. In July 2024, another pulmonology nurse research coordinator was delegated to start encounters. They weren't familiar with the registry, so we went from over everything from the beginning. We trained them on starting encounters, entering PFTs, finalizing respiratory culture results, and notating on the CFB, but they didn't end encounters. So now, while they were starting encounters, that first research coordinator and I were delegated to ending encounters. Our assembly line was moving and grooving. We achieved some speed by dividing the work, but there was still more efficiency to be had. We knew we still needed to continue to adapt our process and explore options for improvement. In September 2024, we created a work group to redesign our workflows. We broke down everything about the registry study in general so we could further identify areas to be made more efficient. Over a period of many months, we examined our data capture and entry system, streamlined a few processes, and got rid of a few duplicative workflows. We refer to this as the registry transformation overhaul and kept the PD clinic in the loop with all the changes made. So remember that separate spreadsheet I talked about, that tool that I mentioned, where I've been tracking certain data points year after year to make life easier for me when the clinic asked for historical trends? That spreadsheet's called the prep sheet. And although it's a very helpful tool, it was also adding redundancy and slowing us down. We agreed to trim many of the data points that we track. Reducing the data points and focusing on collecting essential rather than nice to have data points really seemed to do the trick. Also, having a ticking clock reminding us to stay on track and aim for our goal was a good incentive too. If you'd like to learn more about the prep sheet, you can find my published abstract from November 2021 here and on the reference slide at the end. Okie dokie, what did we find? We evaluated 147 start and end data entry times over 29 clinic flow board CFB spreadsheets from early 2023 to get our baseline, which ended up being around 32 minutes. we evaluated 817 start and end times over 164 CFB spreadsheets from the rest of 2023 through the end of 2024 to get all of our PDSA cycle data. We were able to reduce our time down to 24.2 minutes during PDSA 1 when we trained a new research coordinator and divided the work, down to 15.8 minutes in PDSA 2 when we brought in another research coordinator and to our assembly line. And by the end of the year, during PDSA 3, we examined and changed workflows. We got down to around 11 minutes. So great news. We exceeded our baseline by a whopping 20-ish minutes and our goal by almost 9 minutes. If you look at the graph, the red horizontal line in the middle was our goal of getting encounters completed within 20 minutes. And you can see the blue line shows we're continuing to trend down as we decrease our time. And for those who are a little extra, we even had fancy statistical analysis done showing the p-value, which did show significant change over time in all of our PDSA cycles. And for the folks who like the nitty-gritty, here is a visual of the time study results. I'll spare you the hundreds of spreadsheet rows. Here you can see we have a little snippet of our tracking table for the PDSA cycles, showing the decreasing time per cycle, 32 to 24 to 15 to 11 minutes. Gotta love a spreadsheet. Looking at a snippet of the clinic flow board, here's a side-by-side comparison of two dates of service, the left from mid-2023 and the right from the end of 2024. As you can see, the time recorded inside is showing the improvement. It took us about 10 minutes to start an encounter and 20 minutes to end an encounter in 2023. And by the end of 2024, we're more like 5 minutes to start and 10 minutes to end. The proof is in the tea biscuit. I mean pudding. Okay, so what did we learn? Onboarding additional staff during PDSA cycles 1 and 2 exposed the need to further revise the data entry process. All three of us were able to focus on our assigned roles while being responsible for our specific portions of an encounter. Just like an assembly line in a factory, dividing the work systematically helped us increase our efficiency. Having multiple people who were initially outsiders learn the process brought in a fresh set of eyes that led to diverse perspectives and feedback on how to make improvements. But the credit to maintaining and sustaining our decreased data entry times really goes to that overhaul we did during PDSA 3 when we simplified the prep sheet. We still rely on the prep sheet for tracking certain trends, but it's much leaner. And I think just being mindful that time is ticking away while doing data entry in general made a difference, especially for me. There was definitely a shift in how I approached the data entry process. For example, just kind of like before I was taking my time, reading everything, being thorough. But now I'm just scanning the EMR notes a little faster. It's just, I've got a little more fire, I guess. Being a bit more mindful of how long tasks were taking us was something we didn't expect to find. And it's hard to define quantitatively, but surely was a factor in our success. So we can do thorough, comprehensive data entry and be efficient without compromising on accuracy. We did well and decreased our data entry time with a 36% improvement in 2024. We adapted the process for our pediatric program. Uh-oh, that's weird. Oh, okay. And as the CF model goes, share generously and steal shamelessly. Our adult programs stole this process for their data entry and implemented it by the end of 2024. And we're sharing this with y'all here. So now it's 2025. And we're still seeing fantastic results for both peds and adult. And by early and mid 2025, we were actually able to peel off those 2 nurse research coordinators from assisting with encounters. And by mid-June 2025, I reassumed all research registry data entry for both peds and adults again. Currently, it takes me about 2 to 3 minutes to start an encounter and like 5 to 8 to end. I can really tell a difference, have more time to focus on other projects, and no longer have a backlog of encounters waiting to be finished. The great thing is now, our team is trained on all things registry, and we can cross-cover for each other in the future. We learned how important it was to have a trained backup staff member to assist with data entry when life happens and someone's unable to do the work. Here are my references. We've got the links and the QR codes for each abstract. We've got the CFB that is in the Journal of Pediatric Pulmonology and the prep sheet that's in the Journal of Cystic Fibrosis. I'd like to thank these people right here and acknowledge them for making this a success. Thanks, team. May all your encounters be timely and a wonderful tea party. Feel free to contact me. You can also find my speaker stuff in the profile, the speaker profile on the app or the web. What questions do you have for me now?
Have a couple here. Thank you very much. All right. So when you say start and end encounters, what exactly does that entail for those people that are less, registry savvy?
Okay, so in the registry, when you have an encounter, there are multiple tabs that you can create, and those refer to like body systems and things. So creating different tabs also ties into the full data set, which goes into your grant criteria. So starting an encounter, we create all the tabs. We click all of them except for lab, if there's no labs. And there's no respiratory culture, we won't click that, or no PFTs. But in general, if it's an in-person visit, we'll open all the encounters. And we will put the date, the location, we'll click which multidisciplinary team members consulted with the patient. We'll enter the dates of the respiratory culture, and we'll enter the PFT raw values for that FEV1, FVC, and 2575. And that's it. We just kind of like fill in those and leave it incomplete. And then later we'll go back and read the chart notes, get all the information with the complications and the medications. We'll fill that in later. And then once everything is finalized, we can click submit and we can click complete to submit the encounter. So it's kind of like the same things over and over again.
All right, I got another one here. So who enters the data on the prep sheet, spreadsheet tracking tool? Is it only the RCs, or do some of the clinic staff input their discipline data as well?
With PEDS, our respiratory therapist and program director, she does both roles. She uses that for respiratory cultures, like the method of collection and the patient and the date, and that tells us what information to enter into the respiratory tab of the encounter in the registry. Some of the team members in the PD don't really use the prep sheet that much. The team members have their own tabs in a spreadsheet to record the dates of service that they consult with each patient, and we can use that to reconcile which patients have consulted with, social work and dietitian. The respiratory therapist and program director also utilize the adult prep sheet. Pharmacy does, GI sometimes looks at it, but mostly it's the research coordinator that's manipulating and adding and editing the data and using that to track, all the trends and things.
Nope.
No.
Do I have to push something? Okay.
Oh, she said you can try it again.
Ah.
Can you hear me now?
Yeah.
Hi, Sarah. How did you account for things like hospitalizations, home IVs? Did you account for that in this data or in this project?
No. Whoa, that's so loud. No. Whenever we're let's say you're doing an encounter of a data service for a patient had a quarterly CF visit. When you're doing that, we'll look in all the areas of our different charts. We have 2 EMRs, and that's when we look to see, was there any diagnostics done? Was there a hospital admission? And then we do not time that.
Okay.
That's separate. Yeah.
Okay. Sounds good. Thank you for this hard work. It was a great
Oh,
presentation.
thank you. You betcha.
Okay.
Sorry, one more. So how did you extract the start and end times from the clinic flow board to analyze the time study?
Yeah. Okay, so the spreadsheet is, on the cloud, it's digital. We had volunteers pull up those hundreds of spreadsheets and looked at the columns in the spreadsheet that had, my initials and the date and how many minutes it took. And so the volunteers looked at that, went into a separate spreadsheet, and just row by row for each patient that was seen. Each patient is a date of service, and that has my initials and date, or our initials and date, and the amount of minutes it took to enter that encounter. So the volunteers did that. I worked on it a little. One of our research coordinators worked on that a little. I mean, it was hundreds and hundreds of spreadsheets from 2023 through the end of 2024. So that's all manual. And then we had like statistician and our direct supervisor go through and do all the averages and total all of it. So it was kind of like a manual, like looking and then typing in another spreadsheet and looking and typing just, like 1,000-something rows.
Thanks, y'all.
All right. Our next speaker is going to be Sierra Knapp, and she will be speaking on the Research Coordinator Recruitment Experience in the LTX Ready CF2, a multi-center trial of lung transplant education. Sierra has earned her Bachelor's of Science in Natural Sciences and a Master of Public with focuses in addiction and community health. She joined the University of Washington team as a research coordinator in February of 2023. Within the past few years, she has been the lead RC for several investigator-initiated multi-center research projects, all of which include patient contact with individuals with CF. In her free time, she loves to read, hike, and do anything that involves her Corgi Cooper.
Hello, like Julia said, I'm Sierra Knapp, and I will be presenting the Research Coordinator Recruitment Experience in Lung Transplant Ready CF2. I have no relationships to disclose. The study we are looking at is Lung Transplant Ready CF2, a randomized clinical trial that compares a novel lung transplant education website called Take on Transplant to an existing control on the UNOS website. The overall goal of the study was to evaluate the effect of the website on preparation for transplant discussions. The Take on Transplant website was created in response to information needs expressed by people with CF. With the help of the community, the website was developed. The website provides CF-specific lung transplant education with current guideline-based information, as well as personal CF stories. The study included 11 trial sites and can be completed entirely remotely. If any participants needed Wi-Fi hotspots or tablets to participate, they were provided. We wanted to eliminate any possible technology barrier for participants. This figure shows the breakdown of the study protocol. The study is 6 months long with a total of 4 Zoom visits and a clinic visit. At the baseline visit, participants received access to one of the educational websites, and then after 3 months would get access to the second educational website. The Zoom visits consisted of surveys while participants had access to the educational websites. The clinic visit is part of participants' standard of care that coordinators attempt to schedule with the assistance of their clinic staff during the study visit window. This visit can be in person or telehealth. The sub-study worked in tandem with Lung Transplant Ready CF2. The number of virtual trials is increasing due to the believed accessibility for patients. But to understand if these trials are really more accessible and what barriers still exist, it is important to know the research coordinator's perspective. They are approaching the patients, having conversations, getting the inside scoop. If we want to keep improving virtual studies, we have to learn what there is to fix. For this project, we decided to look at RC perspectives on recruitment and technology barriers in order to improve future studies. Recruitment for the Lung Transplant Ready CF2 study is completed by site research coordinators. The University of Washington staff enrolls participants and completes study visits. For recruitment purposes, flyers with a QR code to schedule a baseline study visit with the UWRC was provided to sites. So let's break down the jobs of RCs for this study. Each individual site RC screened patients at their site and would complete a screening log in REDCap. They would approach their patient about the study and hopefully receive preliminary verbal agreement to participate. Site RCs were encouraged to contact patients up to 3 times, either in person or over the phone. Depending on how the patient was approached and if they received preliminary agreement, the RC has a few options. They can hand participants the UW flyer with the QR code and have the patient schedule a baseline visit at that time, or they could notify UW via email or REDCap that a patient verbally agreed. After being notified, UW would attempt to contact this patient via phone call, text, and email to schedule a baseline visit. In the baseline visit, the UW-RC would consent them and oversee future visit scheduling. UW would pay participants after each visit was completed. To get RC perspectives, a REDCap survey was created. All sites had at least one RC for the lung transplant-ready CF2 trial complete the survey. All RCs had experience with both participants that declined to enroll and that were consented. You may see the sites that participated in this study on the slide. Some questions included on the survey were, what was your sense of the reasons people decided not to participate? How much of a barrier to participation was technology for your patients? Did you find the flyer useful during recruitment? How could we have made it easier to connect people with the UW study team? And was it difficult to explain the recruitment/enrollment process to patients? So what did the RCs have to say? To start, thankfully, technology wasn't a barrier for most. It was found to be a barrier for 38%. Some thoughts shared by RCs were, the issues we had were related to losing phone and not having a computer/tablet, or losing service due to non-payment/running out of prepaid minutes. I think you tried and did enough for our patients, especially one in particular. Some people just aren't comfortable with it. RCs felt virtual trials could improve engagement and made trials more inclusive. One RC said, I think that appeals to patients. They can make it work with their schedule and enables patients who live further away from their centers to participate. Another RC said, I like the idea of a virtual trial. It should give people the ability to participate in research on their own time, making it more inclusive. And one last comment was, love it. It really helped with engagement. People felt they could participate without worrying about getting to another visit. The recruitment process of sites approaching their own patients but UW enrolling was found to be easy to explain and efficient. As previously mentioned, each site was provided with flyers that included UW staff information and a QR code that could be used to schedule a baseline visit, which would eliminate the need for UW to reach out to the participant. 62% found using our information flyer during recruitment very useful. Additionally, 69% did not take the opportunity to schedule a baseline visit during their initial approach. Everything for recruitment seems to be going smoothly, and technology doesn't seem to be a limitation. So what are some of the reasons patients are choosing not to participate? There were the expected reasons, such as time commitment, lack of interest in research, or more specifically, lack of interest in lung transplant. But a big reason was patients would verbally agree to participate with their sites, but UW staff could not get a hold of them to schedule baseline visits, or if they were scheduled, they would no-show and not follow up. Going off that, 54% found it at least a little predictable that some patients said yes to site RC, then never answered UW. The RCs spend a lot of time with their clinic patients, and I had a feeling for some that even though they agreed to participate, they would not respond to UW. Why is this happening? Reasons shared included, maybe if the participant scheduled a baseline visit at the same time as a clinic visit or at a time that the site RC could join, it might help them feel like a comfortable handoff to the UW RC. Communication these days via phone/text is difficult. I wish people would just say yes or no when I'm speaking with them. Some want to think about it before scanning, which is understandable but problematic. UW provided multiple methods of contact in both directions, the ability to schedule without talking to anyone, remote calendar, and did multiple attempts. Going forward, to improve connectivity, we can use a phone number with a local area code when calling people with CF, Patients were contacted by UW via Google Voice, and there were no available Seattle area codes when creating an account. Google Voice was used because we could both call and text patients. It is very common for patients to respond via text versus phone call. We could also have the local RC schedule baseline visits. We provided QR codes and UW staff contact information, but there may be other possible ways to make scheduling easier for sites. Finally, we could complete the first visit while in clinic. This could make a more comfortable experience for participants because they can be assisted by their site staff who they know and have a relationship with while getting introduced to the study, but the limitation there is interrupting clinic workflow. And I know some of my doctors would not appreciate that. We are currently at 125 participants enrolled and are so close to finishing. The process has been efficient and technology hasn't deterred many patients from participating. This is a trial that can be completed fully remotely, and participants choose their visit dates and times, allowing more flexibility for people with CF. The study was successful because of the constant collaboration between site RCs and UW. This was a constant team effort, and all sites did wonderful work. Thank you to the site RCs. I literally could not have done it without you. The co-investigators, and of course UW mentors and staff. I have learned so much from working with all of you, and I'm excited to keep working together until it's done.
Got a couple for you. Great job. So what procedures did UW follow for patient contact?
So depending on how we were notified, I would give a day or two just to let the patient kind of sink it in. And then I would call the patient and hopefully get a chance to talk to them and explain the study more and schedule that baseline visit. If I was unable to get a hold of them, I would send a text message and that would get a response to be like, oh my goodness, I'm so sorry. I didn't answer because I didn't recognize this number. Or we would just text because I'm calling during my workday, which is also their workday, but we would attempt 3 times just like the site. And at the end of 3 attempts, I would email the participant and email the site RC as well to let them know we never heard back.
Talking about all the issues that you did have with Google Voice, if you could do it again, do you think it would have been better to use the UW office phone since it did have that local area code?
I think we had so many participants text. I think it's just so much easier. So, and I also know, because for other studies, I have just called off the UW phone that they don't participate because they just assume it's some random health toll call. So I think texting, even though it wasn't with this area code, did help out a lot.
All right, I got one more here. Let's see. Did you experience any communication disconnections after the participants had enrolled?
Yes, unfortunately we did. We got them in, but sometimes they wouldn't respond or they would no-show to schedule visits. And if I would, again, use the 3-attempt method to get a hold of them via text or phone call. And after that, I would loop in the site RCs or PIs if necessary and hope that they would get a visit scheduled. And some sites were super helpful. So when the patient was in their clinic, they could help us coordinate a visit while they were already there.
Thank you very much.
Thank you.
All right, our final speaker today is Dr. Wolfond. He is a pediatric pulmonologist at the University of Washington and an investigator at the Truman Catt Center for Pediatric Bioethics and Palliative Care. His research includes developing communication approaches for clinical research decisions. He has a long-standing interest in informed consent and research ethics, and he is the co-PI of the ENVISION study, a CF Foundation-funded project to develop a novel approach to informed consent for research. And so there it is.
Thank you. It's a real pleasure to be here. I really appreciate hearing the other presentations. So I am not a research coordinator. I don't even play one on TV. But my wife is a research coordinator. And I think research coordinators are critically important to how we approach and engage people in research. We've heard a number of presentations about their role. And for those of you who are coordinators here, part of what I want to do is talk with you about informed consent, share with you the approach we're developing, and help you see how this can be useful as you approach patients for future studies. My only disclosure, again, as mentioned, the Envision study is funded by the CF Foundation. I'm the co-PI along with my colleague Stephanie Kraft from Geisinger, who's the other co-PI for the study. So we all know that enrollment in CF research is important, but it seems that sometimes people are not as interested in research as they may have been in the past. And there's a lot of reasons why this could be. But I think we have to think about this in the context of modulators. For those people who are on modulators and are doing well, they're healthier, they're busier, it's harder to be involved in a research study unless it's a virtual study like we heard about before. And for those who are not on modulators, they may be sicker, also have less time for research, and they also may be less trusting of the idea of research. Although, again, we heard some wonderful examples earlier today about things we can do, talking to people about studies even when the study's not happening, as a way of developing that relationship. The study protocols themselves are more complex. Often they require a significant time commitment, and studies can be hard to understand because they're so complex. So we often think of informed consent as one of the things that we can do to sort of help people understand the studies. And high quality informed consent is critically important, but as many of you know, consent forms, as the years have gone on, become more lengthy, more complicated, and are often themselves difficult to understand. In fact, there's been a lot of research done trying to figure out how do we make consent forms better to improve understanding. And in fact, a lot of different approaches have been taken, and all the various efforts to try to make consent forms simpler have only modestly improved understanding. And in fact, depending upon which criteria you're looking at, it's usually anywhere between 50 and 75% of people understand any particular item. The one intervention that has seemed to have the most impact on understanding, even though it's still not complete, is conversation. So conversation really seems to be the one thing that does help with understanding a bit. But communication itself is not easy. And I want to bring you back to a book that I read when I was doing my training called The Silent World of Doctor and Patient. And this was actually a book that was really written about the clinical encounter. And I just want to read this quote to you because I think this really summarizes to me the underlying challenge of communication. Above all, physicians and patients must learn to converse with one another. Meaningful conversation, however, requires that both are prepared to trust one another. And powerful obstacles stand in the way of trust and conversation. So we need to figure out how we do a better job of improving research enrollment communication. And I want to point out that although I describe the challenges of understanding, we need to think beyond understanding. One of the ways to think about a research enrollment conversation is to think of this like a clinical conversation that's about a preference sense of decision. We often talk about that as shared decision-making. And the idea here is that we try to identify people's values and priorities. We engage with them in a way that promotes respect, establishes trust, and ideally this also provides an approach that can support voluntary decisions. So the approach I'm going to tell you about today was really modeled after the CF PrEP program, which many of you are probably familiar with, as well as other clinical communication training approaches. We began by identifying gaps in the research enrollment conversations to develop our approach for the Envision study. And the approach we took was a two-part approach. The first thing we did is we created a digital consent tool that includes an overview section followed by a detailed information section. Each of these has simple sentences, limited repetition, as well as graphics and audio. This digital tool, when you press a button, becomes a PDF that becomes a consent form. But the key was for the coordinators to use this tool, essentially like a PowerPoint presentation, as they're having a conversation with the person about the study. But more importantly, and this is what I'll be focusing my time on today, is that we developed a communications framework that we call RIVER, which I'll explain why we call that in a moment, that was developed to focus on relationships as well as supporting deliberative engagement about values and priorities. My main point today is that consent is not about information itself. It's about helping people make decisions based on their values and their priorities. So let me tell you briefly about the Envision project. This began over almost more than 2 years ago in July of 2023. Since August of 2025, 2 years later, we are now implementing this approach in the Stop 360 study in 13 sites. Our goal is to have at least 30 people with CF who are being approached to join Stop 360 will be, coordinators will be using our approach with them. Why did it take us 2 years to get here? Well, the very first talk you heard today was about community engagement. And we had an incredibly complicated community engagement approach. We had a 15-person multidisciplinary steering committee that included people with CF, as well as CF clinicians, as well as communication researchers, implementation scientists, and a variety of people. We had working groups that we created to work on various aspects of the project. We had a health communications collaborator called Booster Shot Media who really helped us develop our digital tool. And we also worked very closely with the CFF prep program who gave us lots of advice and knowledge and guided us along the way. We also, as we developed our approach, had significant broader stakeholder engagement. We got feedback from the Stop 360 leadership team. We identified a number of sites who gave us feedback, both including people with CF at those sites, research coordinators, as well as the clinical researchers. We got further feedback from CFF leaders, both from the TDN as well as the DSMB. And we also did a fair amount of work with IRB staff, getting feedback from them as we were developing our approach. So because of all this and the multiple iterations, it really took us 2 years to get to this spot. So what I want to do now is tell you more about the RIVER framework. I have to acknowledge my colleague, Stephanie Kraft, who's really good at coming up with all these acronyms. So she came up with the idea of RIVER. And what I want to point out is that the R's for relationship and resolution refer to how the conversation begins and how the conversation ends. And it really begins with forming a connection. And at the end, it's confirming that there is a value-aligned decision, that the decision the person makes is consistent with their values. What happens in the middle is the idea of sharing information about the study and eliciting and examining their values. And these two pieces are iterative and go back and forth. So it's some information, some conversation of values, and going back and forth until the conversation is completed. So what I want to do now is briefly share with you a few more details about each of these approaches. And these are things that you yourself can think about as you approach people for any clinical relationship. And, I remember one of the first, I've taken over my career, many communication training programs as a clinician, as a recipient. And I remember one about 10 years ago in which the big focus is, what do you do when you walk in the room? The entire 3 sessions was all about that piece of it. And so the beginning of that relationship is critically important. So we identified 3 things we thought are really important to do. One is make sure when you walk into a room, if there's more than one person, introduce yourself to everybody in the room. Make sure you know who everybody is, why they're there, what their relationship is. Also acknowledge for the person with CF that you're seeing, their personal and clinical situation. Before you jump into the study itself, spend a few moments. How are they doing? What's going on? Really connect with them as a person and find out if it's a good time to talk about the study. They might need to attend to something ahead of time. They may need to use a restroom. They may need to make a phone call. Find out what else is going on that they need to do so they can be focused on what you're doing, because there's no need to rush into it. You want them to be ready to talk and for them to feel comfortable. So I want to talk more about sharing the information. And I think, again, using our approach where we have this consent tool, we begin by orienting the participant and the family to the materials. And we provide an overview of the key information about the study. So we try to give them a sense of what the study is about. In doing so, we share the information in small sections and small chunks. We check in with their understanding to make sure that they're following us along all the way. And we also explore the topics they're most interested in. And we elicit questions and make a list of what their questions are so we can go into those in detail. Because each person will have different concerns, different questions. And we want the conversation to follow their lead, what they want to talk about. And I think that this is really critically important. Even in our actual implementation of this, we find out that what some coordinators often will do is, well, my job is to go through the consent form line by line, sentence by sentence. And, that's not necessarily very helpful. It's hard enough to even read the consent form alone, let alone having somebody go through with you page by page by page. So we really want the coordinators to focus on what is important to the patient in terms of the information that they want to know. They still need to be aware of what information is there, but to really focus your time on the information that's most important to them. One of the novel things that we do during this approach which is really a combination of both information as value exploration, is offering for the particular study some of the reasons why some people join a study and some people don't. And for us, this is particularly important because this does a number of things at one time. One is that it provides 6 pieces of information, critical information that might be the reasons why some people join and some people don't join. And often we need to know what those reasons are ahead of time, but having those reasons allows people to think for themselves, well, where do I fit in with that? Which of these reasons resonate with me? It also normalizes the fact that the choice is one that people make differently. Some will join the study and some will don't. And I think this is incredibly more impactful than saying your choice is voluntary, but because you're now telling them people do different things. With presenting this information, and so what we do for our digital tool, we actually have this as one of the fourth screen of our digital tool. You don't need to worry about reading this because I showed you the information before, but I'm trying to show you the way in which our digital tool works. So there's an image, there is information about the reasons, and this really is probably the most important part of the platform for having this conversation about what's important or not. And based upon what they say, then it allows you to think about how you want to go into more information and more discussion about those things that are most important to them. So when you think about values exploration, you can build on the reasons for and against participating. Again, finding out which ones resonate the most. What other reasons that you haven't mentioned might they have? And how do these reasons weigh against each other? You might want to make sure that you learn as much as you can about their current personal situation and clinical situation. What are their relative priorities? Are they getting married next week? Are they going on a vacation? Are there health-related concerns they have? Find out what concerns or barriers they might have and whether there's ways you can navigate those. And here it's very important to use active listening to reflect the values and the priorities that they've mentioned and really acknowledge those, and you can have more conversation about those. So when it comes time to resolving it, some people after this conversation are ready to make a decision. For Stop 360, this was a decision they needed to make fairly early on because that was a decision for those of you who are familiar with the study. This is comparing 1 versus 2 antibiotics for pulmonary exacerbation. But people sometimes aren't ready to make a decision, and you can at least, or they may have some conflict or concern. So I think it's important to say, look, you don't need to make a decision right away. We can come back and talk to you a bit more about this in a little bit, and then schedule more time to talk with them. So let me tell you more briefly how we're implementing the River in Stop 360. We developed a reference guide, which is actually, I have a copy of it right here. It's like a trifold. Again, besides Stephanie actually having a great way of making names, she's also really good at making brochures. So this is a handy reference guide that all the coordinators can use and look and use this at hand when they need it. We also have a much more detailed conversation guide that's actually much more elaborate, that really walks through each of these steps, gives much more examples of things you can say, ways of approaching this. And this can be useful for training new staff as well as a refresher before the conversations. And while our conversation, and this brochure is generic, but the conversation guide is very specific to Stop 360, but it could be adopted for any study. We also do training for all the coordinators. We have 33 coordinators who we train to use this approach. We've developed videos that we share information with them. We also do a lot of role playing. Our group is very much enthusiastic about theater, and so we love the idea of role playing as a way of engaging ourselves. In fact, as we developed our approach, we ourselves did role playing between ourselves just to figure how is this working? How is this going? And we use that to help modify things. We also have community of practice meetings monthly with the coordinators to find out for those who've used the study. Stop 360 is actually enrolling fairly slowly, so any given month, we may only have 2 or 3 coordinators who actually will have used the approach. We have divided up the group into 2 cohorts of coordinators who meet monthly to talk about their experiences. It's not on the slide, but the other thing we do is we record the conversations because they're using an iPad as a tool, and so that makes it very convenient to record the conversations. We don't track who the person is or who the coordinator is, but it's a way of us evaluating whether or not the coordinator is following the approach we're taking, and we can see how effective we are in our training. So just as this is just another example of what the brochure looks like, the pamphlet. I've got extras, so if anybody wants a copy of this, I have a few of these with me. Please come see me afterwards. This is an example of our our conversation guide. It's a bit more elaborate. These are just the first 2 pages. There's 2 more additional pages as well. So I want to end by saying we are still working on this. We are now in the process of our pilot study, which will be establishing the acceptability and feasibility of this approach. We're doing interviews with all of the people who we use this approach with in terms of the patients. I mentioned we have our monthly meetings with the coordinators. We also have the coordinators complete a survey on a monthly basis if they've used this approach. And we're also doing pre and post project evaluations from the coordinators to get feedback from them how they think this is all going. But we are very excited about the future of this and the importance of having, instead of talking about informed consent, talking about a values-oriented conversation. We think this approach can support values-aligned decisions. It will make, for those who choose to join the study, it will contribute to realistic expectations of what will be involved when they join the study. Regardless of whether they join the study, we hope it'll be a positive experience for the people with CF, and they may be approached for future study, and now they'll be more favorably engaged because of this conversation. And the last thing I'll point out is that the approach we developed is consistent with the regulatory requirements for informed consent. We did have to work with the IRB because if you actually look at the document, it looks completely different from any other consent form you've ever seen, but in fact, it has all of the actual requirements by the regulations. Those requirements are pretty modest, but typically IRBs put a lot of extra stuff in there. And we were fortunate to work with Advara, who was willing to give us some space to do something that we thought would be more effective than the usual approach. I want to end just simply by acknowledging our team. I already mentioned Stephanie Kraft, who's my co-PI. Also want to acknowledge Katie Porter and Sharon McNamara, the 2 co-investigators with me. We also have 2 coordinators and a project manager. So again, our study itself really relies on our own coordinators for our work. And we've had tons of collaborators. We have our steering committee, I mentioned, Booster Shot Media. We work closely with Stop 360, including various sites for developing our approach, participants. And then again, we've met with IRBs from different sites. We've worked closely with the TDN staff, with the CFF staff, and hopefully next year you'll be able to hear more about the results of our pilot approach. So with that, thank you for your attention and happy to take any questions.
Okay, so we have a 2-part question for you. How much time does doing it this way add into the consenting process? And once they're consented in, or once you've talked to them this way, are you going to increase enrollment by doing it this way?
Okay.
What are your thoughts on it?
That's great. Well, we don't know how much time it's going to take yet, but we will have an answer for you later once we have the results from the iPad. We won't have a comparison to know how much it was before, but we have gotten feedback from people that it takes a little more time, but not a lot more time, because they're spending their time doing other things. Rather than going over page by page by page, line by line, they're focusing on the things the person wants to talk about. Now, again, I think it still takes time. I think all of you know that these conversations require some time and attention. The impact on enrollment, I also don't know. We're not, in this pilot, we're not going to have a pilot study for comparison. But here's a couple of thoughts I have this. The goal is not necessarily to increase enrollment. The goal is for them to make the right decision. If it turns out that the reason people are not enrolling is because they can't really process the information and think through what's important to them, then this conversation may increase enrollment. On the other hand, it may, through thinking it through more carefully, they may realize that they really don't have time for the study, or it's not important to them. And while that may not increase enrollment, what it might result is those who enroll may be more likely to stay in the study. I also want to mention, to answer your question not in more detail, but another example is that as part of our role playing that we did in developing this, we would assign each other different caricatures of patients. And one of the patients was somebody who was highly skeptical of research, was really busy. And I was actually supposed to be the coordinator. And I was talking with her about the study. And she started listing all these reasons why she couldn't be in the study. And my response was, well, really, it doesn't sound like you've got a lot of time right now. Probably this is not the right time for you to be in the study. But if you have another exacerbation, maybe it'll be better at a later time. And what ended up happening afterwards, my colleague Katie said, because you said it that way, I found myself thinking, well, I have enough time, I can do this. So even though I was not trying to get her to enroll, in fact, I was genuinely trying to walk it back. And the result of the way we were having our conversation made her actually say, gee, I think I want to do this. So I see a question back there.
Yes. Is this on? Oh, yes. Hi, I'm Kelly. I'm with Providence Medical Research Center, and as you know, I'm working on the River Framework project. I just want to say that we are a big site. We have both CF and the other mini therapy areas, and in our recent huddle that we have every week, I asked if we could teach the River Framework to the rest of our coordinators, because over the last couple of months during these huddles that we have noticed, at least I've personally noticed, that there are some patients out there who really truly didn't really have informed consent or really understood what they were signing up for. And while our other coordinators were talking about, what happened with your enrollment? They didn't understand the billing part, or they didn't understand the follow-up procedures. And I'm like, well, that's in the consent form. How did your consent process go down? Tell me what you did. And she's like, well, we went through the consent form. Mm-hmm. But did you talk about them as a person, not just as a patient who you want to get enrolled in your trial? Yep. So I am just so grateful for this. I'm one of the biggest cheerleaders, I think, for us doing this. And I hope that this goes, I know you've heard me say this, but I'd like to see this implemented in other trials. So thank you.
Thank you, Kelly. And that's actually our hope too. In fact, that's our next phase of our projects, is after this one to try to, in fact, our motivation originally for this project was to do this for gene therapy. But we decided before we could do this in a gene therapy study, we needed to have more evidence to convince the sponsor that this was a good idea. The other thing I want to mention that's actually directly relevant to you, since we're in the same state, we're also part of the University of Washington CTSA, really covers our entire region. And one of the things that we've been talking to is trying to adapt this approach for training coordinators around our 5-state region that we're all responsible for. So we're not there yet, but we definitely have a plan for wanting to sort of use this more generically. We need more. We're learning how to do it. In fact, we're actually now beginning to think about our second study, and we're actually realizing, the amount of training we did takes a lot of time. And so we're thinking through how we can do it more efficiently, spend more time asynchronously, and have more concentrated time together to make that work, so it doesn't take as much time as we did the first time around. Yes.
Hi, I'm Harmony from Portland, Maine. I actually enrolled someone in Vision, so I can answer your question. It didn't take any extra time
Excellent.
To consent them that way. And I couldn't believe that was how it went down. I didn't do it perfectly. The patient was really ill, and I kind of had to, kind of move it along faster than I wanted to. But it didn't add any time to the consenting process like I thought it would. So I was really, I was pleased and surprised by that.
Well, that's really helpful to hear. I also want to comment on the fact that you didn't do it perfectly. It's hard to know what it is to do it perfectly. For those who have been involved with the River training, Sharon and Katie did this incredible video with Sharon as a coordinator and Katie as a patient, in which you get the chance to see how Sharon conducts herself, and she's absolutely incredible. What I want to point out is that the first version of that video was made with me as a coordinator, and we got rid of it because it was so bad. I'm obviously overstating that, but the point is that it is hard to do this. And even when you're familiar with it, it takes time, it takes practice. But I also think that the way you're approaching somebody, you're engaging them as a person, as was said before. You're respecting them. You're creating a relationship. And that's probably more important than getting it exactly right. So thank you.
Thank you so very much.
And if you want a brochure, I've got more of these.
All right. Well, thank you everybody for coming to our session. Just as a reminder, all of these abstracts are also posters, so feel free to go and visit the posters during the poster sessions tomorrow, and the speakers will be there to answer your questions. So thank you again.